mobility, and patient global assessments. I'm not going to go into detail, but I think these are important because of the ASA's recommendations for treatment of ankylosing spondylitis, which we will go over now in the next 5 minutes. The aims and outcomes of ankylosing spondylitis is to improve the signs and symptoms of patients with ankylosing spondylitis, such as morning stiffness, pain, and fatigue, improve their function, that means improve their spinal mobility and productivity, prevent structural damage, such as the syndesmophytes, and hence improve their quality of life. Now, the ASA's and EULAR recommendations for the management of ankylosing spondylitis, everything you need to know is summarized on this slide. Unlike rheumatoid arthritis, here in ankylosing spondylitis, exercise and physical therapy play a very pivotal role. I mean, it's not unlike. In rheumatoid arthritis, it's extremely important, but our focus has been so much on the disease-modifying drugs, but in ankylosing spondylitis, the disease-modifying drugs are playing a less pivotal role. I just modified that, I'm sorry. Slight jet lag. So we have the patients who are predominantly axial disease and the patients who are predominantly peripheral disease. And in ankylosing spondylitis, anti-inflammatories play a cornerstone in therapy. So again, the disease-modifying drug comes later on. Your anti-inflammatories play a cornerstone in therapy. You may need analgesics or surgery. Sulfasalazine, methotrexate, other disease-modifying drugs are only used for patients with peripheral disease. We're not using them for patients who have only axial symptoms. Local steroid therapy is sometimes useful, and then TNF blockers are used in patients who fail anti-inflammatory therapies. So the ASA's also recommends that we have to assess patients with these questionnaires such as BASDAI and use these BASMI indices such as these measurements which we just talked about to assess them in your clinic. So that's part of your treatment. These assessments are highly recommended. And the optimal management is a combination of non-pharmacological and pharmacological treatments. And for physiotherapy, they say, I mean, they sound quite depressed here. They say home-based therapy is better than no intervention. Supervised group therapy is better than home exercise. They're just like anything is better than nothing. So that's the message. Just exercise, for God's sake. So we actually published a small, interesting little case report in Dubai. I had a patient with really bad ankylosing spondylitis and who was on treatment, and he still didn't have improved spinal mobility. And then during Ramadan, he went and he did this intensive Tarawih namaz, and he was praying and praying for 1-2 hours every night. And then he came back, and just that was the only difference. He didn't go and exercise, he just did this. And he came back with really improved Schober's, modified Schober's test. It was interesting. We actually published this, and it was accepted in Rheumatology International and published. So anti-inflammatories are recommended as the first line of drug therapy for ankylosing spondylitis patients with pain and stiffness. And if you are at high risk for gastrointestinal toxicity, you need to use a gastroprotective agent because you're talking about long-term anti-inflammatory use, or you could use a COX-2 inhibitor. And then if you need further pain control, you may use local steroids or analgesics. Again, it says, like I said before, there is no evidence that you can use sulfasalazine or methotrexate for axial disease, and anti-TNF therapy should be given to patients with persistently high disease activity. Now, this is interesting. This is from Arthritis and Rheumatism in 2005. If you use continuous NSAIDs versus PRN or on-demand NSAIDs, there's less radiographic progression. Anti-inflammatories are actually disease-modifying drugs, not disease-modifying drugs, but at least they slow structural damage for patients with ankylosing spondylitis. So this is very, very important for us to remember, because in rheumatoid arthritis, there's a great push for us to take our patients off the anti-inflammatories. In ankylosing spondylitis, there's a great push for us to keep our patients on the anti-inflammatory and continuous, not as needed. Now, conventional DMARDs, as I said, are just largely not effective for treatment of patients with ankylosing spondylitis, and this applies to sulfasalazine, leflunomide, and methotrexate. That's mostly for the axial part. All of us know what the anti-TNF therapies available are, Endo, Humira, and Remicade. And the ASA's response criteria, this is not a head-to-head comparison, is similarly good for all the three drugs as compared to placebo. This is infliximab, etanercept, and adalimumab. And all of them, after 2 years, had long-term efficacy in the ASA's 20 assessments, 40 assessments, and partial remission. Now, the interesting thing is, as Dr. Azra, I think, had touched on, she has a patient on 6 years on this anti-TNF. The patients with ankylosing spondylitis, once you stop the medications, it seems their disease activity goes right back to where you started. So, unfortunately, unlike with rheumatoid, where they seem to induce remissions which can stay prolonged even when we come off the anti-TNF. I've withdrawn several of my patients from anti-TNFs, and they continue to do well. We maintain, because we have a maintenance therapy. We maintain on methotrexate or sulfasalazine, but whereas here, we are not able to really withdraw anti-TNFs. You have to keep them on it. It's very important, and studies have shown us this. It shows anti-TNF, also MRI shows improvement, and but unlike NSAIDs, in ankylosing spondylitis, anti-TNF therapy does not prevent radiographic progression in ankylosing spondylitis. So it's used for symptomatic benefits. So it's almost the complete opposite of rheumatoid arthritis. So just here, I'm going to stop with this slide. The recommendation, when do you start patients with ankylosing spondylitis on an anti-TNF blocker? First of all, we need a correct diagnosis of ankylosing spondylitis. Usually recommended is a modified New York criteria, which we went over before. We need NSAIDs, at least 2 NSAIDs to be tried over 3 months. I heard that the task force just met, and they're saying 2 NSAIDs, 2 weeks each. That's all. After 1 month, you can switch to an anti-TNF if they don't respond. I think that's a bit excessive. If you have peripheral arthritis, sulfasalazine. If you have a high disease activity score, as evidenced by that BASDAI questionnaire, of greater than 4, that's the score, and a positive expert opinion. This is what Dr. Nikat Mir had said. Positive expert opinion is a rheumatologist telling you that you need this drug, then you need to have a high BASDAI score, you need to have failed 2 NSAIDs, and you need a rheumatologist to tell you need this drug, and that's when the anti-TNF is approved. There are several questions. We should not, I think, be withdrawing NSAIDs, or at least trying to maintain patients on some level of low level of NSAIDs. Should an anti-TNF be discontinued? We may not be able to. And what is the choice of anti-TNF? I think pretty much all of them do well, except that infliximab seems to be more effective for uveitis and for the inflammatory bowel disease. That's it. I want to conclude now. Thank you for your patience and letting me run over time. Thank you.